Welcome, everyone, to Vet and Tech webinar series. I'm Jennifer DeBran, and I will be your host. Vet and Tech webinar series is the exciting new way to enhance your clinical skills and gain RACE-approved CE credits. If you'd like to stay up to date with our latest webinars and vet courses, simply download our mobile app, Vet and Tech today.
Today, I'm talking about a clinical finding. As a radiologist, we are often asked to answer a clinical question in addition to giving an interpretation of images. When you look at veterinary medicine lung interpretation, I always teach my students that usually if you are imaging the lung, there is a specific reason why. Particularly in the chest, though, a lot of the reasons why may actually be screening. It may not actually have a clinical sign associated with disease. A metastasis check would be a common reason to obtain chest radiographs in a dog that has no clinical sign. But sometimes you do have clinical signs. Sometimes it's dyspnea, fever. Sometimes it's coughing. This is a dog that looks like he aspirated something. If you look at his lateral view, that's a left lateral, you can see these faint, branching, lucent structures. So to be lucent, they are gas-filled, they're branching and gas-filled, therefore these lucent branching structures must be bronchi. And when you see these lucent branching structures and you do not see a vessel on either side of it, they are effaced, that is then called an air bronchogram. One way to consider the interpretation of lungs that may be more useful than the paradigm that we all have to learn anyway is whether or not a pulmonary pattern is airway or non-airway related. Assigning a pulmonary pattern to being airway related is useful for a couple reasons. One, you can potentially associate it with a clinical sign. So it's nice if you have a finding, if it then matches what is expected for the clinical sign. So if you see something airway related and you have a dog that's coughing, that's nice. Also, it gives you a route for a next step. So if something appears airway related, there's a relatively high chance you can achieve a definitive diagnosis by simply sampling the airway. Versus the dog that had all the nodules. You may, if the airways are completely unaffected in those cases, not get an answer at all by doing airway sampling. You may have to stab. You may have to do aspirates. So it's a route of consideration to figure out how to come up with a definitive diagnosis for whatever's happening. One thing also to keep in mind is the airways, obviously you have a trachea, you have carina, you have those main stem bronchi, and then you have all the lobar bronchi, which then continue to branch into secondary, segmental, tertiary bronchi and keep going. And then you get to the airway exchange areas, which is bronchiolar and alveoli. The structure of them is different. So higher up, the larger airways, which basically constitutes trachea and those larger bronchi, those airways are heavily based on having functional cartilage, keep them rigid, intact, not collapsing, not expanding, all of that. And then when you get to smaller airways, the rigidity or the actual structure is maintained primarily by smooth muscle. And so that sometimes is important when you consider relative treatments for things. Does a smooth muscle medication, is that going to impact larger airways? And then, of course, there's conversations about that too. So the structure of it differs. And then, of course, there's this small, large airway breakdown too. Another thing to consider, because we talked about dilated airways, is the airways that dilate on your images can also equally collapse. So in other words, we have all been trained and try to take images of the lungs when on complete inspiration or full inspiration. That prevents us from making up an interstitial pulmonary pattern. So it's the right thing to do. When you have that and you have airways that have lost their structure, they can dilate like a balloon. They're just floppy. But if you were to see images on exhale, they might then completely collapse. So I have a normal dog on the top row. A is inspiration, B is expiration, and this is the expected diameter change of a normal dog's accessory lobar bronchus. I just pulled that one as an example because it's easier to get on a single slice.
Thank you so much for such a wonderful presentation tonight, Dr. Granger.
Thank you.
So our first question of the evening is mild dilation in a bronchius considered bronchiectasis, or does it need to be pronounced? And when is dilation considered too much?
The metric for it is that if you have a bronchus and a bronchial tree, the closer you are to the middle should always be the most big in diameter. So if it is not tapering throughout its length, either through a section of it or a portion of the lung or a single bronchus, it is then considered dilated. What a limitation of radiographs is, though, is given that it's a 2D image of lungs, it makes it difficult to see mild dilations. So one way to work through that is to assume if it's radiographically visible, it is probably more than mild. But keep in mind, it's usually, if you have bronchiectasis, it's usually lobar, a single lobe. It's rarely diffuse. So if you see a similarity throughout all lungs, it might indicate that you are incorrect making it up, which is always part of the decision tree.
Wonderful.